It's my pleasure to introduce Dr. Andrew Cole, and he is from Hammond Care, and he's going to speak to us today about driving responsibly and other rehab issues that are of concern to patients. So thank you very much, Andrew.
My pleasure. Excellent. We even have a something on the screen and a microphone that'll come up to the correct height for a normally heightened person. I'll be talking about living with brain tumours and driving or not, and travelling, and there's significant issues. And the point is that, as we all know, life goes on after the initial treatment, does it not? Life usually goes on. And one of the difficulties with the initial treatment is that everyone's so focused on the treatment, and rightly so, to make sure it's gotten right for the best possible outcome ongoing. One of the difficulties is that very often after initial treatment there is a degree of impairment. That's to say, physically a person can't do something, or there might be memory issues, or there might be more significant problems with disability, like not being able to do particular tasks for yourself, dressing yourself and so forth. And the question is, what do we do about these things? And until relatively recently, by which I mean when you get to my age, the last 10 years, until relatively recently, not a lot was thought about in really important terms about survivorship after brain tumours. It was almost as if 10, 15, 20 years ago, what are you complaining about? We've dealt with the problem, now get on with life. And things are very different now because there's a whole spectrum of things that can be left hanging out, as it were, after a person's had definitive surgery or radiation treatment or chemotherapy for a brain tumour. And this applies whether the brain tumours are so-called benign or whether they're glioma, brain cancer type tumour. And many people after treatment are left with something that looks a little bit like a stroke. They can have weakness in an arm or a leg, they can have speech problems, they may have troubles getting themselves dressed, or they get their clothes mixed up in the wrong order. Just generally difficult to get on with life. And there may also be less obvious problems with thinking, either with logical thinking or remembering steps in a logical thing, or even mood problems. And if these problems are there and they're arising, the important thing is to ask that these problems are assessed properly by a rehabilitation specialist and a full rehabilitation therapy team who know what they're looking at. That's the really important thing. A, that they're assessed, and they're assessed by a group of people who know what they're looking at. Now, rehabilitation specialists are not very common animals. There's only about 250 of in Australia, and you compare that with oncologists where there's, I don't know, at least a couple of thousand probably. Radiation oncologists, they're slightly rarer birds, but there's well over 1,000 of them, and we're down in the 200 and somethings. But our interest, people come to me and they say, what do you do? And I say, well, what do you want to do to get going again? And it's nearly always some combination of the person says to me, I want to get up, I want to get going, and I want to get out of hospital, or get out of your clinic, or get on with life. And it's a series of words that start with get. I want to do this, this, and this, and this. And so we assess a person with a full medical history and a full physical examination, because we've got to know what it is physically that the person might not be able to do. But we aim to understand the extent of all the person's problems in their own context. So when I sit down and talk with a new patient for the first time, I spend a full hour with them. And I say, tell me about Joe Bloggs. And 90% of people say, well, I thought I first had a brain tumour when. I said, no, that wasn't the question. Because you see, they're so conditioned to think of their life in the terms of the tumour and nothing else. The question was, tell me about Joe Bloggs. And I want to know about Joe Bloggs. I want to know, where were you born? Where did you grow up? Where did you go to school? What did you do after school? How did you meet your partner? And if you're dealing with people in their 70s and 80s, you know the only way people met partners in those days was either at church dances, RSL dances, or on the tram coming home from work. And each generation's got its way of meeting partners, and now it's all electronic. But it's important to know those things, because as I know those things and my rehab team knows those things about that individual person's experience, as we start to think about what we're going to do with therapy in different areas of that person's life, we can customise it to that person's situation, and that is critical. And it's also critical because for every person that's had any significant illness, the single thing that's most important, and I've had at least one significant illness in my time, fortunately a benign one, but it did involve some pretty dramatic surgery at one point a couple of years ago. The most important thing to a person that's undergone a significant medical problem is their story, their narrative, my narrative. And if we're not interested in the person's narrative, we're not interested in that person. So I aim to understand the full extent of problems in a person's own context. I want to know what's going wrong physically. I want to know if that's impinging on relationships inside the family. I want to know where that person is in terms of coping with their mood, and also want to know what's the meaning of that illness to them in here. Now, I'm one of those old-fashioned types that talks about matters of the heart. And we all know that the heart's very important and it doesn't just pump blood. Okay, matters of the heart are very important, you know. I was driving here this morning, I was driving to work this morning interviewing John Paul Young. Do you remember him? Love is in the air? I thought that's a matter of the heart, I've ever heard it. Things that mean something to that person in life, because we can't work out what that person means that they want to do with getting on with life until we know what that life means to them. So then I let them loose on my team members. And usually the first team member that comes in and gives the person a good run for their money is a physiotherapist, because the physios are interested in problems where muscles aren't working properly, where they're not being controlled properly. If there's a balance problem, or even anyway, even if a person hasn't got too much in the way of focal motor weakness, you've only got to lie in bed in a big hospital for 2 weeks and not do very much, which is the definition of what often happens after surgery, to waste your quadriceps muscles by about 30 to 40%. Okay, if you really want to do it, you can try it, do a John and Oko routine in your own bed at home, have a lie-in for 2 weeks and refuse to get out of bed, and you'll be very shaky on your legs when you get out because your muscles deteriorate when you're not using them. We are designed to be dynamic people. We're designed to walk. We're designed to do. We're designed to get into arguments. We're designed to, you know, do all those things around the house, walk around, get in the garden, do all those kinds of things. And if we're not physically active, then balance and endurance problems are things that our physios work on. And I, as a doctor, and my physiotherapists in that part of the team work at the level of predominantly physical problems in the person's life. And they're relatively easy to see if they're present. Next level up, though, is occupational therapists, and they deal with functional problems in daily living. So if you've got a physical problem, it then means there's a series of tasks you can't do. Maybe you can't wash or shower yourself properly. Okay, if you've got right neglect and you're falling over to the right-hand side in the shower, that's not very safe. Or if you've got left neglect, particularly you might be dressing yourself and your clothes are all in a muddle because they're inside out and back to front. And that's normal for a 3-year-old, because I've got a couple of 3-year-old grandchildren. Since this time last year, my unfortunate youngest daughter-in-law had a terrible surprise because she went along to her first ultrasound for her second child, and that was when they saw 2. So my fortunate son has now got 3 under 3, which meant that they had to move house, buy a new car, and do everything all at once. But they're managing quite well. Nevertheless, the oldest boy does dress like sometimes people dress after a stroke, and, you know, full marks for trying, but that has to be re-taught. Move on to feeding. If a person needs to be able to cook safely or even shop and then do leisure activities, all of those are daily activities that you and I need to do as part of our normal life, okay? Because if I haven't done those activities, as I walk in here, my hair will be like a haystack, okay? I won't be shaved properly, or if I've got left neglect, I'll have one side of my face shaved or the other side not, and well, that's a great prank. After a couple of days, it becomes rather obvious, and if I haven't had a shower, I'll probably be whiffy after a couple of days in Sydney summer with a sweat. Speech therapist also functions both at the level of impairment and at the level of functional problems. At the level of impairment, sometimes after brain injury, with a cancer or a meningioma, if it's very extensive, there can be swallowing problems. And swallowing problems need to be dealt with really quickly and worked out, because a swallowing problem, if your food goes down the wrong way into your lungs, can carry you off a whole lot quicker than just about anything else after surgery, with the exception of clots in your legs. But then the long-term things are communication issues, and one of the classic clusters that we see is a person that's got a brain tumour in the frontal lobe or the middle lobe in the brain just above their ear on the left-hand side, and they will have the classic cluster of some weakness in the right hand and maybe the weakness in the right arm, some problems with speech and vision on the right-hand side. And all you've got to think about is some excitable person somewhere from Southern Europe or the Mediterranean who's talking a lot, and you realise why the voice in the right hand and seeing things on the right hand side are intimately connected inside the brain. And the speech therapists assess communication and work out after treatment, are there particular communication things that we can do to improve that person's ability in their communication so that the frustration level goes down. Because a lot of people with this particular communication with brain cancer can actually understand quite well what's being said to them, but they can't say what they want to say. And when it's really difficult, they don't quite understand that they're not saying what they want to say. And oftentimes a word will come out that means something like the word that they want. So they might say table instead of chair. You know, I want to sit on the table. Well, sure, why do you want to do that? Or they might come out with another word that sounds like a chair. I want to sit on the flare. How do we do that? Or they might just get totally blocked up and only be able to say a few words. So impairment at the first level, function at the next level, finally participation at the uppermost level is the social worker's role, looking at family and care network issues at home and finances, accommodation, community problems. And all of those things need to be assessed in a rehabilitation setting. Now, very often, after acute care in a hospital, there are social workers there. They do deal with those issues. Usually if a person's got very significant weakness on one side, they will get access to physio. They may get access to occupational therapy, but the difficulty is that you can't kind of force a brain tumour patient into a standard stroke rehabilitation program, which is what tends to happen in a lot of places. It needs to be differentiated more than that. So once you've assessed the person, what we do with our team, each of my therapists and I myself, discuss the person's goals with what they want to do. Because one of the things that I discovered very early on in my parenting life, when my children got to about the age of 3 and they started to say no, which is, you know, the single most important vocabulary in the average preschool child's age, between about 2.5 and 4. And I've had one that kind of was 15 going on 2 before she finally stopped saying it. If you can't work out what the person wants to do for themselves, they won't be motivated to do it. I mean, it's so obvious when you think about it. I mean, I'm only motivated to study for exams that I'm interested that I want to pass. Okay, I'm not interested in studying ancient Sanskrit at the moment, though I have great respect for those few people at the university who do. I'm not interested in that, so I'm not going to pass an exam in that because that's not one of my goals right now. So we sit down and we talk with a person. What is it you want to achieve in particular areas? Because one of the things that makes people who've got significant leftover problems after a brain tumour depressed and down is that they can't do things. And they feel dependent. And everything in our world, here in Sydney in particular, is about being independent. Okay? I've lost count of the number of times I've been to Thanksgivings and memorials and all that sort of stuff where the main tune that was featured was "I Did It My Way." Okay? And that's almost a theme song about the two big things that are valued most in our community. Okay? One of which is independence, and the other of which I have got increasingly less of as I get older. And I teach medical students this, and they provide various rude options to answering the second question. But the second thing is, of course, youth. Youth and independence are the two big things that people value around us today. So understanding what a person wants to do and achieving a simple goal in the first week of treatment, having another conversation about the next week of treatment, achieving the next goal and achieving the next goal. After a couple of weeks of that, the person starts to think, goodness, I'm improving. I'm doing things for myself. And the mood lifts. It really makes a difference, really makes a difference. So providing the correct rehabilitation therapy at the best time and in the right place in the whole process is very important. And where I work at Greenwich, and we have close relationships with North Shore and Mater in one direction, with the Macquarie University Hospital in another, and to a lesser extent with some people that come across to us from either Wales or Vincent's, we actually interdigitate our rehab therapy if they're having ongoing radiation treatment. My physios and OTs will flog them in the morning, give them a good run for their money, then they go off and they lie on the table and have the healing lights shone on them by somebody at North Shore or wherever else. They come back home, they feel really tired, they have a good night's sleep, and it all starts again the next day. And I'm very kind to my patients. I give them 2 days rest every week, Saturdays and Sundays. Okay. But the thing is that having that timetabled and interdigitated in with what's going on with the acute therapy means that the recovery that's happening after the primary therapy, if there's a significant deficit, that recovery is maximised. And we now know, comparing those people with stroke patients that have strokes in similar areas of brain, that the results of rehabilitation for brain tumour patients and stroke patients where the problem is in about the same area of the brain is very similar. It's good news. It's good news. So we review the effects of the therapies provided, we regularly check with the family, and we keep going. So the next thing people said, well, I'm getting up, now the next thing is I want to get going. So what do we need to do to get around in the community? It's very natural to want to get up and about just as soon as acute medical care is completed, but to do safely mobility in the community, you need to be able to do a couple of things. The first thing is because mostly in Sydney the public transport's not wonderful, unless you happen to be living on a metro line that goes out into the far northwest of this city through suburbs that I didn't know existed until my youngest boy bought a house out there, because that was where he was able to buy it. You have to be able to get safely to whatever mode of transport you're getting on, and that means you've got to not only be able to walk within a controlled environment in the hospital where everything's lovely and level, there's no bumps in the ground, there's no dogs, there's no runaway kids or yahooing teenagers. You've got to be able to move safely. Are there steps? What's the ground like outside? Are there uneven pathways? We've got to know what it's like for you to get into your house. Getting in and out of a vehicle. Okay, SUVs are wonderful to get in and out of, because the seat is just about, depending on the SUV, the really big ones, the seat's just about the right height for my backside with the knees bent down. And even for a shorter person, a slightly smaller SUV like, I don't know, Jimny or something like that, still is about the right height for a person to back up and put their knees against the edge of the seat and literally lower themselves onto the seat, swing the legs over. You try that, getting in and out of a low car, it is murder. Getting a person right down and getting a person right up, they need a lot of strength in their legs, or they need a carer with a really decent back to get them in and out. SUVs the go. And the other thing is, when you're travelling around in the car, you've got to be belted in no matter what. One of the things, though, that does happen with getting around, after a surprising number of people that have had brain tumour surgery, is when they first get in the car, travel sickness can be a real issue. Just driving around Sydney. Now, I know there's a lot of roads closed and you're going along a road and suddenly the road does that and then suddenly it does that, especially if you're near the tram tracks around Kensington. God knows where the road is there. I mean, going to Peters nowadays is just an obstacle course in itself to go and buy anything there. But one of the things that's important to think about, if a person is starting to get a kind of a giddy head sitting upright, is it something simple like they've been lying down for such a length of time that when they sit up, the blood pressure drops? Easily measured, easily fixed. Review the medications, make sure they're getting enough fluid intake for the output they're doing. If they're really having trouble with their blood pressure reflexes, we've got this thing called a tilt table, which is basically a bed that goes anywhere between there, and you strap a person in and you bring them up to 30 degrees, you're feeling dizzy. Oh, well, we'll leave you there for half an hour. Therapist goes away, does something with somebody else. Leaves a little button so the person can buzz if they're feeling dizzy. If you're not feeling dizzy, we'll take you up to 45 degrees. And if you've lain flat for a couple of weeks, I have to tell you, 45 degrees feels like a very steep roof. Okay, it's not the same as vertical, but it feels very steep. And you can retrain blood pressure reflexes very quickly over about 10 days. Sometimes, though, it is simply related to the fact that the person's 3D perception of where they are in space is altered as a result of the surgery and lying down for a prolonged period of time. And you get in the car and you do a couple of roundabouts and a few riding or bends, and you're thinking, where am I? Okay, it's worse than, taking a sailing ship out to the outer islands on the Barrier Reef. So things that we need to check as far as the ears are concerned, it's really easy to get hard wax inside your ears when you're in hospital for a couple of weeks. You're not doing that in the shower every day. Is there a blocked middle ear? If a person's got a problem with the brain stem and the eyes aren't fixating too well, if it's worse with head movements, it's worth trying something called cyclozine, which was a travel sickness pill which used to cost 2 cents a pill when I was a child, and it's now a special prescription item that costs the taxpayer considerably more. And if you can understand the ethics of that American drug company, then please come and explain me. Anyway, the other thing is to sit as a front seat passenger. The best way to get rid of motion sickness is to sit where you can fix your eyes on the horizon. Okay, if you want to go to the Barrier Reef and you want to go out there in an impending typhoon and you want to be a hero, stand outside on the front, don't look at the waves. Look straight at the horizon, and the boat will be doing this, but because the boat's doing this and your head is fixated on the horizon, your head is not doing that. And that's what causes the motion sickness. If you look at your feet, then you'll be doing that. You'll be seasick in 30 seconds. Today's useless fact. I hope it's helpful one day for you. Okay, so what about driving, which is something that people ask about all the time. It's a very complex task, okay? You probably can't remember, or you've repressed what it was like the first time you learnt to drive a car. But the most important thing with driving a car is a bit like playing a piano. You have to do it without looking at what you're doing with your hands and feet. You've got to look at the road, okay? Playing a piano, you've got to look at the music. Look at your hands, it's fatal. You lose your place in the music. Look at the music. If you don't know where your hands are going automatically, it's really hard. And when I learnt to play the organ, you've got to do it with your feet as well. But I figure if I could learn to play the car, I could learn to play the organ, and that was how it worked out. But the complexity is not just control, it's also keeping your place on the road, keeping your place in the lane, which is why they'll fine you if they catch you with your mobile phone in your hand, because you're looking down here and you're not looking ahead to see where the lane is. And if you see a person drifting to and fro and driving slowly in and out of lanes, you know what they're doing. They're not looking at the road. And we've got to be aware of other people on the roads. Keep a safe distance, and whatever we do, avoid physical contact with every other vehicle. In every situation, number one rule of driving, you'll stay out of trouble forever. And all that needs good eyes, good ears, good cognition, good thinking and good judgment. And the issue then about driving is that it's overloaded with a social issue. For most blokes in this country, being able to drive a car and being independent is a crucial part of most blokes' identity from the age of 18 onwards, right? Take your I was going to say, not allowed to call them Sheilas anymore, are we? You could take your nearest and dearest to the drive-in and sit and hang out for a couple of hours and go back again and not be dependent on public transport. All that stuff to do with being independently mobile. It's a very strong part of personal identity, especially for men. Not to say it's not an important part for ladies as well, but especially for men. And public transport, I've said, often depending where you're living, is quite inadequate. Okay, where I happen to live down the bottom end of Oatley, it's about 1 kilometre and a bit walk to the railway station. The trains are really good when you get there, except the latest timetable means that 2/3 of them don't stop anymore. They sort of go through and wave at you, which is a bit humiliating, but there we go. But there is a bus that comes down our street 3 times a day. Twice on Saturdays and never on Sundays. And it gets worse the further out you get. So, how do we go about driving a car? Legal issues. The first thing is to say that driving is a privilege. It is not a human right. It is a privilege regulated by law, and 3 groups of people are responsible. There's a triangle of responsibility. The first part of the triangle is the person with their hands on the steering wheel. But the other 2 people are the healthcare workers that are supporting and assessing that person, and the third part is the driver licensing authority that actually issues and stamps the passport. Now, for the individual person driving a car, anytime we get into a car, and especially now in these days of climate change, whether you believe it's human caused or not, the first question we need to ask ourselves is, do I actually need to do this drive? And generally speaking, after a brain tumour, one of the things that a person who wants to drive needs to ask themselves is, do I actually need to drive? Because if we have an accident, we're responsible. We're the primarily responsible person. So the law says that if an individual driver of any situation, brain tumour, diabetes, you name it, has medical problems, They must be declared. They've got to be acknowledged, okay? We need to have insight to realise that we have problems with those issues. And it's one of the other areas I work is with frail older people with dementia, and older people with dementia are just dreadful for not realising that they're quite dangerous driving a car, because I've driven a car for 70 years without an accident. Well, keep going, you might have one. And if a person has chronic medical problems, they must report these to their doctor and or the driver licensing authority, who are the people that used to be called the RMS, but I now think they're sort of called Service New South Wales, and they do everything, including birth, marriage and death certificates. The second part of the triangle, the health workers, mostly doctors and therapy staff. And for us as health workers, our question is a different question. So my question when I get into a car is, do I need to do this drive that I'm about to drive, and am I safe to do it? My question as a health worker, looking at a person who's in front of me, is, do I think this person is safe to drive a car in the presence of other people on the road? So I've got to consider the effects of illness on your daily life and the big ethical dimensions there. I have to think about the effects of disease on function. I have to advise very impartially if it is or not safe to drive. And if a person is not safe or ignores my considered advice not to drive, it is actually my responsibility under law to report that person not taking that advice. And then the third group are the driver licensing authority, and they're an allegedly intelligent life form that lives on the other side of the Blue Mountains, somewhere near Bathurst. And you ring them up and you talk to this disembodied voice on the phone many, many miles away in the country, and they answer the question, is it legal for X to drive or not? And their job is to get the information from the individual person that holds the licence. The healthcare workers that look after them apply the standards and issue the licence. And on the licence it'll tell you you're either safe to drive or you're not safe to drive, or to drive with conditions. And if you have a driver's licence on you, if you could pull it out, just trying to think, a few of you in the room, not as many as my medical students who all tend to wear glasses because they've been studying too long already at the age of 25. Most of them have got a condition on their licence already, on the back of the licence. The top of the licence says what you can drive, and mine says a vehicle seating up to 12 adults, weighing up to 4.5 tonnes, and I can also drive a tractor and an implement. Never driven an implement, but it's one of those bucket shovel things that you can dig holes in the road with. And underneath there's conditions. Now mine hasn't got conditions on, but if your vision is such that you need glasses to be able to see traffic lights, it will say you must wear glasses or contacts as a condition of your ability. And if a person doesn't comply with the conditions on their licence, then there's legal sanctions to make them comply. So thinking about assessment, the three concerns now are not the same as the first time I got our licence. First of all, can the person control the vehicle? What's the functioning status? If there's really bad weakness in one hand or one leg, does the vehicle need to be modified? And that's the same kind of questions we run through after a stroke. And does the person understand and apply the road law, especially if there's new cognitive changes, but also because the road laws are changing all the time? Okay, 2 years ago it was quite legal to pick up a mobile phone and dial a number while driving along. That law's changed and gone. Okay, 15 years ago, only one state, well it's a territory really, sorry, only one state in the country had roundabouts. The other places were rarities. There was one at Miranda, there was one at Five Ways at North Ryde, and I can't remember where the other one was. Oh no, Daceyville, you know, around near the big Greek Orthodox church at Kingsford there, where they're putting the tram terminus. There was only 3 or 4 roundabouts in Sydney, so you didn't need to know about roundabouts. So most drivers who are 50s and 60s up still don't know whether they need to put their blinkers on going in and out of roundabouts and which road they need, you know, lane they need to go in and so forth. And that's an example of a road rule that has changed dramatically in the time since a person's got their licence. And those are things you need to check in an assessment. So the practical steps: full medical history, full examination, and then the doctor makes a decision about driving or not and records what it should be. And then that decision is made official, and if I'm making that discussion with the person, I'll always have the families there as well, because just occasionally there are some people, surprise, surprise, that don't like the idea that they can't drive the car at all, or they're not allowed to drive the car at night, and they'll happily go and do it and tell the family that Professor Cole told me it was quite safe to do it. Mind you, lots of my patients do that. It's not just brain tumour patients. There's people with dementia and people that keep falling over and people that want to go on a long trip when they shouldn't and, you know, all that stuff. Anyway, so making it official means that the driver licensing authority needs to know, so that if there's an endorsement that goes on the licence, it's done, or if the licence needs to be cancelled, that's done as well. And the other thing is that if a person goes back to driving after a brain tumour, they must be followed up. Because one of the things about brain tumours is we know is that they're dynamic and they're unpredictable. So you can have some people who'll go 20, 30 years without a problem. You'll have some people that'll have a problem within a couple of years, and some people unfortunately can start developing problems in a month or two. So specific problems in New South Wales, if you had a blackout, no driving for 6 months. Never tell a cop you had a blackout as a means of getting out of an accident, because you won't be driving for 6 months, okay? If a person has epilepsy, 6 months after a fit, if it's properly treated, you can drive. 12 months if there's no primary cause. If a person's got neurological deficits like weak arm, weak legs, so forth, after treatment or after onset of neurology changes, not for 6 months. And if a person has got visual field problems where they can't see half the world, obviously, never drive again. Never drive again. If there's a visual field problem or the acuity's not right, you make sure that you're wearing the right set of glasses and your visual fields are broad enough to see. If there's a large brain tumour and there's worry that a person's judgment may be impaired, like not being able to react quickly enough when they're driving, get a rehabilitation opinion. And generally speaking, getting a commercial driver's licence is not appropriate after treatment for a malignant brain tumour. Because when you're driving commercially, you're driving something that weighs many tonnes, or you're driving a bus with 30 or 40 other people in it, and you might take the risk for yourself, but doing it otherwise is not good. All that, up to an off-road test and an on-road test, is usually covered within the system, but the last two are not, and they cost about $1,000. People complain about that, but I've had 4 children that I've taught to drive, and I have to tell you, apart from the dollar cost on my hair and my mental health of teaching 4 teenagers to drive, is that it actually ends up costing pretty darn close to $1,000 a kid to get a driver's licence first time around, let alone the second time around, just by the time you've paid for somebody else to get rid of the bad habits you've taught them and so forth. Final question to talk about is travelling longer distances. People always ask this. People want to go and see family. I have a fair number of patients who, because of where I practice, have come from Hong Kong or Malaysia or Taiwan or even Japan, and they want to go back and see family, they say. I know what they want to do is they want to go home and try some Chinese medicine. And I say, well, that's fine, yeah, you can have Chinese medicine, just be warned that it'll cause diarrhoea, and that's the main effect of most Chinese medicine. We haven't yet found a cure, but if you do find a cure, please come and let me know, and then you and I can publish a paper and we'll get a Nobel Prize. But travelling longer distances, generally speaking, a couple of hours on a bus or a train is usually okay. You just need to think about how you're going to get through the check-in, okay, whether it's a bus or a train or even an aeroplane, and how you're going to get onto the vehicle. Can you get in and out of the vehicle and onto a seat? And generally speaking, if a train's available, it is preferable to bus if you're not driving a distance for a couple of hours. Trying to get up steps into a long-distance bus is really hard work. Have you ever watched some of the older people trying to get up onto the steps of the bus at Central Railway to get the bus to Eden? It's a wonder that more of them haven't got broken hips from tumbling down. The other thing is that disabled accessible toilets are usually present and quite easily usable on trains. Bus disabled accessible toilets are just awful. In fact, bus toilets are pretty awful anyway. And the question is, if you're going to travel any distance, is there a helper available? Air travel, more complicated, okay? You've got the hassle of getting to the airport, getting off at the curbside. If a person has any mobility restriction at all and they're going to fly, always wise to wise up the airline and say, we need a wheelchair to help get through. It saves so much trouble. But you need to be scanned. You need to take off all the metallic things and all that sort of stuff, go through the scanner, and you need to go to the boarding gates, sorry. I must have typed that a bit late. Nothing to do with that certain irreverent comedian. But the distance of getting to a boarding gates from the front curbside on an airport, at Sydney Airport anyway, is often in excess of 1.5 kilometres. There's acres of duty-free shopping. And it's only because you're walking through it, looking at the stuff there, you don't realise how far you're walking. Disabled people really do need companions on flights of more than a couple of hours. Consider that ordinary flying seats are very cramped. I have terrible troubles myself on an ordinary aeroplane. If a person's taking the one special trip to Hong Kong to catch up with family, spending an extra $1,000 to go economy plus, where the seat will recline an extra 15, 20 degrees, where you've got extra leg room between, where it's much easier to get in and out of the seat to go to the toilet, is well worth doing. Some A330s and A380s in particular have got toilets at the back of the main economy cabin and at the front of the economy plus cabin, where two toilets can have a wall open between them. And you've actually got enough space inside a pair of toilets. Well, two people, I guess, can, have a happy little meeting in there at once. But one person has got plenty of space around them for an assistant to help them get on and off a toilet over a 10 or a 12-hour flight. Obviously, we need to make sure that people aren't going to get clots and give them the right medications to try and prevent that. The other thing that's not immediately obvious is that cabin pressures of aircraft, most aircraft, flying on an aircraft is a mountaintop experience in more ways than one, which is why when you arrive at the other end you feel a bit dry and a bit dizzy because the cabin's pressurised at about 2,500 metres above sea level. So if you can get to the top of Kosciuszko without feeling too dizzy after a brain tumour, then fly in a standard aircraft. Boeing 787s, the jetliners, Dreamliners, and the new Airbus A350s for the long flights. So for those of you who know, the 787s are flown by Japan Airlines, Nippon, Qantas, United, Singapore. And the 350s are flown by Finnair, Malaysian, and I think Garuda's got a couple of them. Because they're made of plastic, those planes, as well as metals, they're stronger and lighter, so the cabin's pressurised at a higher pressure, so that you don't get off feeling as tired, you don't get off as feeling as dry, and the mountaintop experience is only 1,700 metres, which is, the height of the mountains around Mount Victoria, which is not quite the same height. So, summary. For rehab and for driving, we need to know thoroughly and impartially assess the safety for living activities. We need to know as a driver or as a healthcare worker, depending where we sit, our responsibilities legally in regard to driving, and the outcomes might be that the person's not fit to drive, might be that they can drive with limitations, might be they can drive without limitations. And the message with long distance travel is yes, it is possible, preferable with an assistant, and with planning, with letting the airline know. The more preparation there is ahead of time, the better the experience is going to be. And finally, as with everything to do with brain tumours, follow up, because brain tumours are a chronic disease. And every chronic disease, things change, whether it's rheumatoid or diabetes or regular strokes or frailty and arthritis or brain cancer. Things change, and the assessment that you did last year may not be the same as the assessment this year, and there might be some therapy you can apply now that wasn't relative before that is worth doing. Thank you.
Thank you very much, Andrew. I know I'm keeping my eye on the time because we do want to finish at 3. Is there any really quick question that someone would like to put to Andrew before he leaves the stage?
I'm sorry? Travel insurance. Yep. Well, yeah, the thing, insurance is like driving a car. It is also not a human right. It's something that we buy, and the cost of insurance goes up with the risk. And it is true that once a person's had a brain tumour, their risk of complications is higher than my risk or somebody else that hasn't had a brain tumour, and the insurance people will price that risk into it. Bear in mind, though, that there are numbers of countries that have what's called a Medicare reciprocal arrangement with Australia. So, from memory, places like the UK, Ireland, Italy, and I think Malta there's probably a few others in Europe that have a social health scheme like we have. I wouldn't go near America for a whole range of reasons. I mean, they'll shoot you there. But for a whole range of reasons, but particularly if you have any significant health problem, going to America without travel insurance is just a disaster. For people going to stay with family in places in Asia, generally speaking, the family in those situations will pay for anything that's necessary that happens to them while they're away. They're just so pleased to see them. So I do explain it's really hard to get travel insurance, but if you're happy to take the risk and that's what you really want to do, that's the goal you want to set yourself, I'm happy to help you try and achieve that goal.
I get it, but with so much price and coverage and everything, and I suppose this just few questions, not like a long sheets. And one question was, how long was my operation?
Yep.
And I cheated a bit, I did not advise for immediately.
Yeah.
And I was so stupid, I talked to my children about it, and one is so important, so critical, and she didn't, and she said, no, she didn't tell it was the cancer. I always remember, so try to decide that.
One of the things that's very important about insurance, whether it's a car or travel, is you must be honest about what's going on. So if you tell the RMA that you drive a car without scratches and you have an accident and they find the scratches that existed before you had the accident, you're in big trouble. So there's ways you can express things that are true, but I've had exactly that experience. I mean, I have a travel insurance policy because I travel overseas every year a couple of times for meetings and things, and the cost of my overseas travel insurance policy doubled after I had heart surgery. But the heart surgery was completely successful, the valve's fixed better than it's ever been in the last 50 years, but nevertheless the cost of my insurance doubled, and I think, oh well, just grin and bear it. You know, it's one of those things. Sorry. Yes.
Just a quick comment. The BTAA actually did quite a bit of research into the travel insurance when you've been diagnosed with a brain tumour. So if you actually look at the BTAA website,
Sorry, I forgot to mention that.
Brain tumour section, they've actually done a really good review of, but it is very hard. Most travel insurance won't actually insure you for once you've been diagnosed with a brain tumour.
With anything.
Yeah.
Thank you very much.
Rheumatoid, heart attack, you name it.
And thank you very much, Andrew. We really appreciate your talk.